Apologies for keeping you waiting. We'll just. Can you see my screen? Just wanted to check.
Yes.
Yes, doctor.
Yeah, just a minute again. Some issues. Yeah. Apologies for the technical glitches. We will start today's panel discussion on strategies to overcome the challenges in management of spinal cord injury. And today we have a very esteemed panel which have joined us. Dr. Matthew Varghese needs no introduction. Dr. Sanjay Wadhwa, Dr. G. Balamurli, Dr. Gaurav Sachdev, Dr. Hara Prakash, and Mr. Shivjit Singh Raghav, Vishakha Darak Thakkar, and Nishad Qasim. So we will start with the discussions for the panel discussion. Just a brief introduction. We know that till around 8 decades ago, outcomes of spinal cord injury were very poor, and it was described as an ailment not to be treated. There were stalwarts then who revolutionized spinal cord injury management during the Second World War. And today we can say that life after a spinal cord injury can be happy, meaningful, and worth living. But notice the word can, because this statement still doesn't hold true for many people living with spinal cord injury in India and many parts of the world. India was slow in responding to the revolutionization of spinal cord injury management. And there are various reasons in this regard, like with other emerging countries. One, it afflicts the lower socioeconomic strata. Two, it is expensive management. Three, the immediate benefits of treatment are not obvious as in other ailments. And four, it is not commercially viable. Though the burden of spine injury is omnipresent, it is the underserved areas that take the biggest impact. And we talked about spine diseases in general. Socioeconomic, political, ethnic, and cultural factors lead to the poor availability of spinal injury poor availability of services for spinal injury in underdeveloped regions. Low-income countries face 56% of the global disease burden, but account for only 2% of the global health spending. These are World Bank statistics. We have also published, and it was very apparent from the publication, that financial constraints affected all components of spinal cord injury management in all except the upper Kupusami group. If you look at the Indian socio-economic scenario, the average GDP per capita of $1,900.7 as against the global $10,925 some odd dollars. And as per the World Bank, a third of the Indian population falls below the international poverty line of $1.25 per day, and 2/3 live on less than $2 per day. Public spending on health has remained low. Health insurance coverage is 10% in urban areas. Private out-of-pocket expenditures on health are amongst the highest in the world, as per the World Health Organization Global Health Expenditure Database. It was 62.7% in 2018. Financial factors leading to non-treatment of ailments in India has doubled. Situation seems to be grimmer in the rural areas. And borrowing or sale of assets, ornaments, and draught animals was observed to be double in the rural hospitalized cases as compared with the urban ones. So because of lack of spine care in the underserved areas, people often storm through an unending downward spiral on various aspects, whether it's physical, psychological, economic, and so on. So we see there is a substantial gap between the possible, that is life after a spinal cord injury can be happy, meaningful, and worth living, and that actually available to the people living with this devastating injury. So we published the challenges in comprehensive management of spinal cord injury in India and the Asian Spinal Cord Network region, both in the Spinal Cord Journal as well as the ISCOS textbook. However, we know that there are opportunities as well. There are strengths within the Indian scenario. And this only focuses that there's a need to develop long-term region-specific realistic goals and brainstorm on strategies to improve access and quality of spine care to underserved areas. Many developed countries have set up a robust health spine care system, and their best practices may provide a clue to the possible solutions. Hence, we thought about this seminar on strategies to overcome the challenges in management of spinal cord injury. So let's come to the first question. Can best practices and key points from developed countries, which have a robust spine healthcare system, be just implemented in underserved areas to improve access and quality of spine care? May I request Mr. Shivjit Singh Raghav to address this question first?
Thank you, and good evening to everybody. Hope I'm audible.
Yeah, very much audible, Shivjit.
Thank you, sir. Okay. You see, it may not be possible to follow what Western countries are following exactly. But yes, to develop a good protocol or strategy for spine care, we have to take a few of the things which are happening all over the developed countries rather. You see, no doubt India is a very different socio-economic, cultural background if we compare it with other developed countries. And our people with spinal cord injuries, as you just showed in your slides, are majorly from very poor economic background, not so well finances are there to have. So I won't agree to that we should totally take up what Westerners are doing, because we have very different scenario in India rather. But yes, there would be many things which India can take rather than reinventing the wheel on so many things. Many good things about which already developed countries have come up can be imbibed in our protocols and strategies or what we follow in our country. But the whole program won't suit to India as such, rather, what they are following, because I have been to Stoke Mandeville and a few other places, and I have seen what sort of money they are spending on rehabilitation and what sort of infrastructure they have. But that may not be possible for so many persons with spinal cord injury to afford that rather. And that is not needed also at times, because as we said, their culture is altogether different. They hardly have any social support, family support and things like that, which in India is quite better scenario is there. We have a strong family bonding and support that makes a difference rather. And their people are on their own. So they want to be as independent as possible. And so they have very different approach towards the rehab program. I won't say, India people, although need the same, but we can't imbibe the whole of things as such rather. But yes, few good things, as I said, we can definitely. Thank you.
Thank you, Shivjit ji. Dr. Harihara Prakash, do you have anything to add on this?
Sir, thank you for the opportunity. I do totally agree with Shivjit, because yeah, like one recommendation cannot fit all. As he correctly mentioned, the cultural diversity that we have and the socioeconomic status which impacts the overall recovery of a person who undergoes spinal injuries. So this needs definitely a different recommendation, but definitely there are a lot of good guidelines which the developed countries have taken up, which we can look into those things. We can customize those guidelines and look into our needs, and we have to fit it accordingly, so that we could able to meet out the needs of those people with different cultural diversity. But at the same time, we need to have that positive human and economic impact which we have, the cultural diversity, the social support system, and we need to have a close follow-up to see to that how the progress over the time has made. We need to invest more time in looking into understanding the the system which is there in abroad countries, and we need to closely study, invest time, and improve our spinal care globally, so that we could able to meet out those things. More than anything else in our country, what I feel is the recommendation, rather than treating, we should focus more on prevention strategies, because as we all know that India lives in the rural area. Fall is one of the major thing, and the law and order is not that much in place. So the focus should be more on prevention strategies, which we can be an example for outside other developed countries. And yes, I agree with the other points which Mr. Shivjit ji also told. Yeah.
Thank you, Dr. Harihara Prakash. Vishakha ji, you agree that strategies should be adapted and individualized based on local needs and availability of resources?
Yes, totally. I totally agree with them that strategies need to be adapted according to us, because we as a country, we are so diverse. Take an example of geographical diversity. Like there are so many areas which are hilly areas or not accessible areas, wherein we need to give intensive training to our people so that they are able to navigate their wheelchairs on those streets, on those lanes. And there are so many other cultural differences, as in like the people is still in the households, people sit on the floor and do their kitchen work or do other works. So we need to teach them those lower surface transfers and all those things which require these cultural adaptability. Also, by the time I believe the people reach our rehab centers majorly, the crucial period that, like in other countries, it's like 21 days they reach the rehab centers, proper rehab care, whereas in our country it is not really what we see. Very few people are actually able to reach till the rehab care in the initial stages. So by the time they reach, there is a lot of financial exhaustion. They try every possible means for the recovery. And then, as you've already mentioned, the financial constraints. So yes, that is, so again, the effectiveness of outcomes really becomes difficult, or rather delayed, because of these constraints. So yes, we should be doing according to our local needs and resources that are available.
Thank you, Vishakha ji. Dr. Gaurav, would you want to add anything to that, or would you agree with what has been mentioned?
I think the consensus has already been made that strategies should be adopted and individualized based on the local needs and availability of the resources. I mean, if we take the example of single use or reuse of catheters while doing intermittent catheterization, we are still debating it with our friends from developed countries. And even though there is a question mark on affordability of single use out there as well, but how many Indians can use, say, for example, single use catheter? I agree that availability of resources and individualized needs, without definitely compromising on the safety of the patient, that should define the strategy. Thank you.
Thank you, Dr. Gaurav. We will move on. Just a minute. So I think there is consensus amongst that strategies should be adapted and individualized based on local needs and availability of resources. I don't think any of our panelists would differ on that. We have to assess the need of the area, the resources, and the weak links. And an individualized approach with some standardization should be followed per se. But we come to the next question that would focus on low-cost, high-impact practices be a solution for underserved areas? If yes, could you illustrate with some examples? And here we would want to address this question to someone who is very passionate about it and has been working in the field for a very long time. Dr. Matthew Verghese.
Thank you, sir. Thank you. I think we can clearly look at low-cost interventions and make a difference to these people. And as our Shivjit and other colleagues just mentioned, that because of our cultural backgrounds, diversity, and the family bonding that is there, there is an opportunity where instead of having institutionalized care, instead of having caregivers who are expensive, instead of having support systems that are very expensive, relatives of patients, particularly the family members, can be trained to do 2-3 key interventions that change the outcome for a patient with spinal cord injury. There are 2 areas which everyone believes can make a difference, and these are bladder and bowel, and the other is bed sores. So most patients that come to me, they have exhausted their resources, but they come to me with either very bad bed sores or they come to me with renal failure, and their lifespan is reduced because of renal failure. And both these can be done very, very prevented with very, very good low-cost interventions. Train the family member. If there is a mother or a father or a wife, they can be trained for clean intermittent catheterization. They can be trained for the bed sore prevention, early recognition and prevention of bed sores. These are very, very simple, very cost-effective, but highly, highly impactful activities that can make a difference to the longevity of the patient with spinal cord injury and for the quality of life of a person with spinal cord injury. If you look at the lifespan of spinal cord injured patients in the West, they compare with the near normal lifespan of the other people without spinal cord injuries. Whereas in our countries, their lifespan is reduced because of renal function problems, because of poor management. And poor management has to start from preventing a bladder problem. So therefore, the primary care that is happening, and it has to happen right from the most peripheral centers, because many of these are highway injuries. Many of these are falls from trees and electric poles in the rural areas. There, the primary healthcare people do not know the emergency management of bladder to prevent over-distension of bladder. They keep waiting that maybe he'll pass urine, maybe he'll pass urine, maybe he won't have, a bladder involvement. And by the time they reach a secondary care or a tertiary care facility, bladder is over-distended beyond repair. And then you've lost a huge opportunity. So right from primary healthcare, a low-cost intervention training, simple, early bladder management to primary healthcare and secondary care people, primary subsequent management of clean intermittent catheterization. Even soap and water is just good enough. Soap and water is just good enough. You don't have to buy expensive catheters. Soap and water is good enough for these, and the research has shown. It's the classic example of the Vellore, the CMC Vellore, one of the earliest rehabilitation projects in India, started by Mary Verghese. The current team that is there, they're doing a remarkable job of trying to train these family members in 2 key things: preventing bed sores by turning them, and early recognition of the early signs of an impending bed sore, and 2, the clean intermittent catheterization. And they have made a huge difference. They have reduced their bladder infections by a dramatic to as low as 7%. They have reduced, they have improved this fecal continence to as high as 77%. And they have reduced the bed sore to as low as, less than 10%. So this thing, which is possible by a community participation, family participation, and by group therapy that they have, where people get together, where people that are experienced in handling spinal cord injury are exposed to people that are not experienced, fresh, spinal cord injured patients. So there's a huge opportunity here. We can make a difference, and we need to look at, these are very key things, the bladder and the bed sore.
Thank you, sir. Dr. Balamurli, would you want to add to that, quoting some examples in addition
Yes,
to
sir.
what Dr. Matthew Verghese has mentioned?
Yes, sir. Thank you for the opportunity. Well, if you just look at the topic about low cost and high impact, we have to actually look deep down into what actually determines the cost of spinal cord injury care. I agree with Dr. Matthew Verghese about how we can prevent complications, which reduces the cost. But if you look at when healthcare provision, either in the public sector or in the private, are providing spinal cord injury care, what determines is infrastructure costs, equipment costs, manpower costs, accessibility to where they can come. So these are all the important factors that determine about how we can define the cost that the patient has to pay. We need both in the urban as well as in the rural. So the cost of care going to vary between the urban and the rural. So some of the methods that we can use, and from my experience with HAMSA and working with Rotary and various other NGOs, what we have realized is that, if you can have similar spinal cord injury setups outside of an acute hospital, that really makes a big difference, because providing care within an acute hospital is very expensive. So this cuts down the cost. Once your cost is low, accessibility becomes easy, and there'll be more people who would want to take, because we all know that this is a disease of the lower socioeconomic status. Second is a lot of new centers which are emerging, which I see are very expensive because of expensive equipments and infrastructure. And I think if we can cut down on these, more healthcare providers would want to provide this at a reasonable cost, at the break-even cost. Because at the end of the day, if you want to run a successful rehabilitation setup, you do need to be able to provide a good service. At the same time, you cannot have losses, then you cannot sustain on that. The next thing that we can leverage is the digital technology of connecting people. So, in the rural areas, you cannot always have the senior doctors, the rehab physicians, and people who can connect. So, like CMC Vellore and many other places, they've taken on to telemedicine and other digital networking, forming local networks of spinal cord injury groups. So these local groups meet at least this is the scenario in Tamil Nadu, where the spinal cord injury network in Tamil Nadu, they conduct meetings in every district every year, every month. There are small gatherings. So I think education of the family, education of these, and accessibility to specialists through telemedicine, digital networks, this will all cut down the cost. It will make accessibility for the patients, so they don't need to always travel to hospitals for many things. So I think these are some of the points that we should think about.
So it's an important topic. Does anybody else in the panel have anything to add to this? So if not, we move forward. Another important question. So before that, as also mentioned by our panelists, we know that we can adapt. We can find local solutions like the Patna model, where we train attendants for spinal cord injury management, and by various like the family support and the community support, we can come out with low cost, high impact practices. Also, this is a wonderful example of a model of pre-hospital trauma training for laypersons devised in Africa, where at a low cost, they have tried to improve the pre-hospital care which can be provided to persons with injuries. And
so,
coming to the next question, what role can policymakers in underserved areas play to improve access and quality of spine care? This question I would want to pose to my colleague, Dr. Sanjay Vadhwa, please.
thank you, Dr. Chavda.
Hmm.
Actually, policy makers are very few in India, and often there is lack of continuity. People move on, the policy gets stuck, and many a times you need strong leadership or will from the top to push any policy in terms of implementation at the ground. I'll give an example. There are so many challenges in the spinal cord injury care. And instead of developing every 4 years or 3 years or 5 years new strategies, there is a strategy for comprehensive health care coverage across the country through the Ayushman Bharat scheme. But it feels sad to say that under the Ayushman Bharat scheme, the spinal cord injury care is very poorly represented. It has a wide network. Many people with spinal cord injury are not aware of the benefits and their coverage. And it took a lot of effort from me, and I'm sure, Dr. Chavda, you must have also tried hard to push the packages as far as the health benefit packages as far as the spinal injury person are concerned in the Ayushman Bharat scheme. There is a lack of awareness. And for example, Dr. Matthew Varghese example of the CMC Vellore, I'm aware of that model, but again, it feels sad to say that very few people are aware of this model outside the Vellore and outside the network of the spinal cord injury caregivers and planners like us. One of the important things can be that there are so many new aims being set up by the government as a priority. If there is inclusion of spinal cord injury care and management in a systematic way at all the new aims, it can have a very long-term ripple effect. When I look at the competency-based curriculum of the undergraduate medical students, there is not adequate representation as far as the spinal cord injury subject is concerned. So there is a need to strengthen that as a strategy so that if every young medical undergraduate is sensitized to this important condition, later on when that person becomes a specialist, whether orthopedic or any other field of specialization, the person is already sensitized enough. And then things will change, because the first contact of a person with spinal cord injury is either with a basic medical doctor or with a basic health nurse or with a therapist. And if all the curricula of all these people are relooked and it is ensured that there is a coverage of the spinal cord injury, then a lot of change can take place. And lastly, the products which are required by persons with spinal cord injuries, they should be easily available across the country. They should be affordable, and there should be a facility and provision for repair and replacement of these products. And these are very much lacking areas in this thing. This I feel is very important to pay attention to. And of course, all that is good that is happening must continue, but there should be dissemination of that information. Very few people know about the Patna model of care. Not many know about the Vellore model of care. And similarly, there are a few other models of care. So we need to popularize all these models of care, which are low cost and relatively high impact. People get carried away that it is a very expensive illness. No doubt it is expensive, but everybody does not need motorized wheelchair. Everybody does not need silicone catheters. So we need to work on that. And there are strategies in terms of universal health coverage, because the situation may come when the government asks a question, can we have strategies for so many individual conditions? Why not try to ensure that all the conditions which are important from the public health point of view, be covered under universal health coverage. And simultaneously, the insurance component has to be strengthened so that people with spinal cord injury can get reimbursement because it is an expensive illness. Thank you.
Thank you, Dr. Sanjay Wadhwa.
Dr.
Nishad
Komal
Kasimji-
Kamra has mentioned just now that even PMR has been removed from the MBBS syllabus. That is not correct. PMR has not been removed. What had happened was that when I was president of my association, IAPMR, I had prepared a document and a representation to the Board of Governors. Earlier, physical medicine and rehabilitation was an optional subject under the list of subjects for the new medical college, which is to be opened. But I pleaded and represented to the Chairman Board of Governors with many documents for justification, and I was successful in getting it moved from the optional list to the essential list. So 2 subjects were made essential for a new medical college. One was physical medicine and rehabilitation. The other was emergency medicine. But about 2 weeks ago, the new notification from the National Medical Commission has removed 3 subjects from the essential list for the new medical college opening. They have not removed the subject from the MBBS teaching training program. The 3rd subject is pulmonary medicine, whereas everybody felt that the importance of pulmonary medicine has been highlighted beyond any doubt by the COVID-19 pandemic. But then later on, when I dug deep into that, I came to know that there was a discussion. And in the discussion, they felt that perhaps pulmonary medicine may be appropriate as a subject for the super specialty area. But till date, there is no clarity why physical medicine and rehabilitation was removed and why emergency medicine was removed.
Yeah, I'm sure that would be rolled back because in an era where even the Prime Minister has been giving more focus on rehabilitation, there is no scope for reversal on that stand.
Yeah, I hope so. And
Across the
sooner it
country.
is done, better it will be.
Mhm.
Thank you.
Right. Thank you. Nishad Kasimji, what role can policymakers in underserved areas play to improve access and quality of spine care? Would you want to add more on this topic?
Good evening, doctor, and respected all panelists. So my thought again, it actually supports to Dr. Sanjay's comment of whenever there are policymakers, they should have a consistency in the follow-up. So right now, when we spoke about a resource centers in each of the rural localities, now there is an order which is already pending of 2015 that a regional spinal center has to be established to facilitate the services. And it's sad that only 4 states have right now established such kind of a facility. So creating more such kind of a facilities, I feel can give an access to rehabilitations, because there are some NGOs like us who work on the remote last mile, but there are a lot of challenges basically when we approach into the primary health centers or probably to a community health centers in terms of accessing the services to people. The first question that we do get is about the what do you call, a kind of a license that we would need to practice in community to provide this kind of a service. Despite there have been a lot of knowledges that has been translated at the last mile, the acceptance still remains a very, very major query. And some legal measures has to be taken to promote the good practices that has been taken up. And Dr. Matthew also mentioned about the caregivers being taking the major role. It's a cost-effective model where a wonderful impact has been created. But there are a lot of cost-effective model. For example, very recently we had a Mission 200 project where around 239 beneficiaries with with pressure ulcers were healed. Roughly around 74% completely healed just by training the caregivers on an appropriate method. So when these kind of models are existing, so there should be some systems which can facilitate this to be one of a model and promote it among the countries, or maybe different medical facilities kind of. The next important thing is about the accessibility things. So as we already know that the rules are already existing, like by 2025, India should be completely accessible. But despite considering the fact currently what we are undergoing, there are a lot of gap in terms of understanding the accessibility and also to provide facilities, because there are many problems. Like when we go into certain places, there are accessible facilities, but it's not following the proportions. So unless we have a unified system all across the country stating that these are some things that is mandatory for a person with spinal injuries, or maybe certain guidelines like a practice guidelines, let it be a treatment guidelines, or it could be an accessibility guidelines, or it could be an employment guidelines. Unless we have certain things drafted by unanimous bodies, I think it becomes a real hard task for implementation at a last mile. So the policymakers basically should be looking into these aspects not as a rehab, not as a medical management. It should be like a 360 evaluation about the person's need, like how, in the previous speaker already mentioned about the quality of life and the life expectancies, making sure that it is almost equal to that of a normal man in the Western countries. So unless when we start looking into that perspective, I feel that getting equal opportunities or maybe inclusions may not be practically possible. And that would be my suggestion towards the policy that we will be looking forward.
Thank you, Nishad Kasimji. You all have been working a lot in this field, and so we value your opinion on this. Shivjit ji, would you want to throw some more light on this?
You see, what we have talked so far, and what we understand that in the metropolitan cities and even two-tier cities, we may have many facilities. Rather, it may not be enough, but yes, there are facilities for treatment and rehab and management rather. But what we need to look into is into rural and three-tier cities, and there where the accessibility is not there. And no doubt the policy makers can definitely make a difference to the care there. And you see that what we have, the tertiary, primary, and secondary setups rather. So at least the primary setups which are there, even with PHC or at a panchayat level, those ASHA workers and those can be trained to at least the beginning can be made from there rather. But as Nishad mentioned, we have to have proper drafting of policies rather, which needs to be, because mostly the government people go by the book rather. They, if they do not have some policy on the in the book rather, they won't go beyond that rather. So it has to be very the protocols and those things have to be framed in a larger context. And in the rural areas, we definitely have to have a little different approach than the metro and two-tier cities.
Thank you, Shivjit ji. Now, I would just want to come back to Dr. Sanjay Wadhwa and ask him, is it important to develop and follow local clinical guidelines and protocols? If you agree with this, try to drive home the point with a suitable example.
I agree with it partially, not fully. See, many a times the resources and the kind of expertise at the local level is limited. So when there are global high quality guidelines, we can definitely take that into consideration and modify or tweak it depending upon our local needs, the profile of the patients, and the resources, and our facilitators and barriers. So exactly replicating and copying an existing guideline or protocol is not possible. But here I agree with the slogan that think globally, act locally. That is very important for the spinal cord injury management and rehabilitation. So when there are good examples of good clinical practice and management of spinal cord injury in developed countries, where the model systems of care have been developed, where the data collection and analysis and representation and dissemination is excellent. We can definitely learn from that, and instead of reinventing the wheels. But the kind of causes of spinal cord injury, the kind of first aid, the initial response, and manpower available, those things are very different from what we have or we lack in India. So here we have to utilize our strength, which has been earlier also expressed, that our strength is strong family bond, though it is nowadays very often said, but in reality, our family structure is also crumbling. The family size is becoming smaller and smaller, and very few families are now left with joint family structure and system because of the cost of living and many other social and other factors. So I feel that we have to have a mix of both. There are some advantages of retaining some of the good things of the developed world, which have tried and tested. And we have to also be aware of our own local needs, constraints, and resources. So a mix of both is always likely to give a better result.
Thank you, Dr. Sanjay Wadhwa. Dr. Harihara Prakash, your views on this?
Yeah, right, sir. Thank you so much for the question. When this was asked, I was just trying to go back to my experience. There is a place called Dang, the Dangs, which is the border to Maharashtra and Gujarat. It is absolutely a tribal area. We had a visit as part of our community training program. This happened almost 8 to 10 months before. And to my surprise, that is completely a tribal area where there is high inaccessibility to any nearby hospital. The place where we visited, the nearest hospital to the place is the headquarters, which is Ahua, which is around 30 to 40 kilometers. And the other side is Surat, which is around 120 kilometers. These people are uniquely placed. There are around 60 families that were put together. There may be around 150 to 200 people. And to my surprise, when we did a small survey, there were more than 15 to 20 people who suffered spinal cord injuries. And when we looked into their needs and their the way how they are, there are a lot of guidelines and protocols across. But this institutional based rehabilitation will never come into picture because it is unlike head injuries where it is not life threatening. People are lying down on the houses are not pakka houses, they are kacha houses, just on the floor lying down, living for almost months to years together. Complete unhygienic environment with lots of pressure sore and everything, and there is no any accessibility to the nearby hospital, and their health seeking behaviors are quite poor. They are not bothered about because they are living their life till God gives. There is no any good health seeking behavior, and they are in a very poor the quality of life is very poor. So that time we were just trying to understand. Then we could able to fit into a CBR program, community based rehab, where in fact, as Dr. Wadhwa said, it is the guidelines are there globally, but we have to customize their needs, and we have to focus only on giving them some aids through which they could able to sit themselves. We have to give some modified chairs with a hole where they could able to defecate, not on the floors, and this sort of bedsore management. Most importantly, when we looked into their way of life, there are a lot of hillocks. They have to climb the hill to get their livelihood. They climb on the trees. In the earlier remarks, which I said, most of the injuries of this, almost 80% were fall from the height. So the guidelines needs to be very well clearly mentioned over there about prevention strategies more than treatment strategies. So area to area, place to place, the geographical locations and their health seeking behavior needs to be definitely considered while we plan a protocol or devise a guideline, keeping in mind the existing one, which is there globally revered with a lot of evidences. So here in this place, it is absolutely CBR which can only play a role. There is no any scope for IBR, and the people are also not in need of any other hi-fi thing. They are waiting for the death to happen. The nearby members, they are all going on to their day-to-day life activities. They just happen every day. They just come and they are not being taken care of also. Here the role is absolutely different, working on the prevention strategies and giving them the basic needs taking care of their pressure sores and transfer activities. It's absolutely a rehab program which needs to be customized to the local needs, added on to that. So we have to give them some exercises training, transfer programs, sitting strategies, support strategies. So all those things. So keeping the protocols there, we have to create a local guideline which will fit into the local needs. So this is one such example where I picked up that Dang as a main area. If you go into deeper areas, every area geographical locations needs different protocol. We have to customize it not alone to the area, to the person also, but keeping those protocols in mind, which is globally approved. That's what is my opinion, sir.
Thank you, Dr. Harihara Prakash. Anybody from the panel wants to add to what has been discussed?
Hi, Dr. Chavra. I just wanted to mention something along these lines. See, a country like India is so diverse in rural and much more interior, like what Dr. Harihara Prakash said. If we try and come up with a baseline model through the Spinal Cord Society or something, for an urban, what is the basic requirement, for a rural, for a much more rural, a basic, because we don't need to reinvent the wheel every time to what it is. Definitely, I agree with all the panelists that local adaptations are required, but it only needs a slighter modification. So it can have like a tier 1, tier 2, tier 3, tier 4 kind of a different model. So one of the difficulties I've seen when groups of people want to start a rehabilitation, a spinal cord injury rehabilitation, they don't know where to start. They don't have a basic guideline. They don't know what is equipment required, what are infrastructure required, what are SOPs to be followed. So for our country, if we can come up with some guidelines where, for a private setup, this is what is required, for a rural, urban, something like that, if we can all as a group come with consensus, it makes easy for such adaptations like what Dr. Harihara Prakash said. They can immediately implement this in a tribal area or in a rural area or something like that. So it's just a little thought that I had following these discussions.
Dr. Balamurli, on those lines only, the Spine Trauma Study Group of the International Spinal Cord Society has worked on a grading system for spinal cord injury centers, right? So the requirements, the basic principles of management remain the same, right? So those need to be followed and they can't be compromised. But then you may have various grades and then a network of centers such that those which can't provide comprehensive facilities, they could tie up with centers of other grades so that there is a network of centers which provide comprehensive care. So, for example, it is not possible for all centers in the country to have all tertiary services to provide management for polytrauma cases. So once the acute phase gets managed, the patient could be referred to a center near the place, which may just have rehabilitation facilities, right? But such a network needs to be created. So we are almost in the last leg of this, and we should come out with the publication soon. We have taken opinion of people from around the globe through an ISCOS survey also in this regard.
Thank you.
Thank you. Thank you. So going further, some technical issues that have been facing. Just a minute. Well, no issues. I will move forward on that. Some issue. Yeah. Is my screen visible? No.
No, it's not visible.
Yeah. Just. For some reason. Is it visible now?
Yes, it's visible.
Yeah. So, now, just wanted to come to the next question. I think we have talked about policymakers. How important is advocacy? How important is advocacy and public support? Can it impact or can it impact policies? So can we have Dr. Bala Murali comment on this?
Yes, sir. So I think yes, it's absolutely important for all stakeholders in order for to have a successful program, especially the public, because it starts from various lobbies and various groups that has to influence local governments, local bodies, districts, the state governments. So it has to be a massive movement that has to happen, and I'm sure a lot of things are happening. But at a local level, there has to be significant changes, and this is only possible by public opinion, by local groups, and by advocacy. So nothing will happen if groups of people keep talking unless we move towards having a policy at the central level, which has been implemented and percolates all the way down to the local bodies. So definitely it is required. I'm sure people have more experience than me in this, which can talk about this.
Yeah. Vishakha ji, would you want to add something to this?
Sure, sir. Thank you. So I would like that if we can get law students, regular individuals, people on wheels, if we can add them, encourage them to pursue law, and then they get into the policy making, so that will probably make a huge difference. As in, the people who are on the wheels, they know it better how about the policies and what they exactly need. So we can look into that. Also, as the previous speaker had mentioned about the medical students being trained, likewise, if the students, I mean the school students, are also being trained and being made more aware about this, so things will change. And also, if the local groups or advocacy or public supports can come up and try and form a local rehab care, like halfway home or something like that, wherein we have seen people who have lost both the parents or the family members and they have nowhere to go, or people who have lost very elderly couple, the parents are very elderly and they have no support group. So these such kind of people, or women particularly, after the incident, after the accident, the husbands have either left them or taken away their kids away from them. So some policies can be made wherein the marriage protection law or something like that is made into. So this is what I feel.
Thank you, Vishakha ji. Nishad Qasim ji, you people have been involved substantially with advocacy, and you've been working with public support. What are your views? Can it impact policies?
Absolutely, sir. Like, I just wanted to quote few of the examples so that it makes us understand how important this advocacy basically is. Like, just taking an example of 5% reservation fund. So many times when people do not have their affordability to get the rehabilitation for us, basically it's 10,000 rupees that we charge them. So even that becomes an unaffordable concept for many of the rural dwellers. So when we started asking for this 5% reservation funding in the local panchayatis and kind of thing, there was a huge resistance basically because they themselves are not aware that this funding could also be used for a rehab facilities kind of. So when we had this peer trainers basically creating a lot of advocacy, they training the users at the last mile about what all of their rights and entitlements. And when they formed a group, a CBO was being created. And then and there was a lot of changes in terms of government response with respect to what do you call the policies that has been implemented. So I think advocacy plays a very, very major role. Many a times, taking another example of abandonments and the property issues among the among the spinal injury survivors, basically. So this also had a lot of impact in the families. So when these groups, CBO network groups, were created at the last mile, so this team started working as an advocacy, as an advocates. So this had created a lot of impact, so that they also feels that there is a support system that is existing within the community, like a social responsibility that has been created. So I feel advocacy is everything for last mile users, because that creates sustainability rather than any, what do you call, any resources from a top level controlling the system. So I feel this is very, very important in the system. Thank you, sir.
Thank you, Nishad Qasimji. There is a comment from Captain Shishir. Without effective advocacy, nothing will move forward. Take example of acid attack survivors. 2 years of planned advocacy program enabled them to get added into the disability list. So totally agree with you, Shishirji, on this. I think the views of the other panelists are also on those lines. So,
Even the rights of
recognizing the need of advocacy, a global advocacy initiative called Spine 20 was launched, and we recently met in New Delhi, and many of you were involved in that initiative. And there have been studies which show that public support for policies in a range of domains is sensitive to evidence of their effectiveness as well as their ineffectiveness. So public support doesn't come just like that. It has to come with effectiveness, and recognizing that only, 5th September is observed as Spinal Cord Injury Day across the globe, recognizing the need for advocacy in this regard. So coming to the next question, what is the importance of dedicated research to improve access and quality of spine and spinal injury care in underserved areas? And I would want to request again Dr. Harihara Prakash to address this question.
Yes, sir. Thanks for this question. Of course, that I do 100% agree that we need to have a dedicated research in improving the quality of life of people with spinal cord injury and to create accessibility to those people. But most importantly, before we talk about dedicated research, I would like to refer to the acronym GRIP, that is getting research into practice. I've been exposed to this spinal cord injuries and all through this platform ISICON maybe a decade before. And when I was looking into a lot of research work which has been done, but when we see that how much has been put into practice, so the research has not been converted into practice in many areas. There are a lot of guidelines, protocols, and Spinal Cord Society is working so hard to bring in a lot of guidelines, clinical guidelines, protocols, and measures. But the sad story is that as we go deeper into multiple places, India, again referring back to as a country with diversity and lots of thickly populated, there is no percolation of that research content which is really working in putting into practice. So I personally feel that, of course, as it is a two-arm, one arm there should be a dedicated research where people, there should be definite guidelines and most importantly, this interprofessional education and interprofessional practice where the collaborative research is needed, multi-centric research is needed, where we need to create database and informations. But on the other hand, in the other arm, there should be a dedicated team which will have to disseminate those findings which has been done so far, which is there in the literature, which has been time tested, proven, whether it is there across the country where that practice is there, whether those information has been reached. That is very important. Converting the research into practice is still lacking, in my personal opinion. In my own places also, as we read in so many materials, there are a lot of bottlenecks when we want to put into practice, because it is not a one professional job to take care of a person with spinal cord injury. So many people come into picture. There is a spinal surgeon to orthotist to counselor to recreational. So many people are there. Interprofessional practice is lacking. That domain, specific work, communication between the practitioners, I feel that we need to really work on putting that into practice, and dedicated services, interprofessional research, multi-centric research is very much needed to create accessibility, promote inclusiveness, and making them as a productive citizen is highly needed.
Thank you, Professor Harihara Prakash. I now want to ask Dr. Matthew Verghese to comment on this question. What is the importance of dedicated research to improve access and quality of spine care in underserved areas?
Thank you. Whether underserved or overserved, research is key to your progress and improving quality of care. Unless we evaluate what we are doing, unless we understand the outcomes of what we are doing, we are not doing justice to what is being spent on whatever care we are giving. So that's an important part. We don't need to look at earth-shaking bench research. We can look at simple things like Dr. Hariharan was mentioning about the spinal cord injured patients in those tribal areas. They are waiting on the floors, waiting for their death. Now, how many of them are having a life expectancy that is normal? If I were to ask a national figure, what is the life expectancy of a quadriplegic? What is the life expectancy of a tetraplegic versus a person without these problems? We won't have an appropriate answer. The problem with the research in India is we want busy clinicians to do the research work. We do not plan and budget for research. Without a budget for research, where a manpower who understands the scientific methodology of doing research, the scientific rigors of a research intervention, they do a simple case series. And when it comes to making a policy and look at the grade evaluation of that paper, you won't have a quality there. So what we do at the core research in these, even in the underserved area, should be based on robust research methodologies. That is important. Unless we do that, there will be case series which will be dismissed by the peer-reviewed journals, and they will not come in our guideline development, and we'll reach nowhere. So eventually, we'll only be developing consensus. So if you're talking about guideline development, we need to generate local data. We need to generate local outcomes. For example, what percentage of spinal cord injury patients are able to access assistive technology products? Because majority, more than 70% of these patients, to some extent can be made as functional movers. Functional mobility is possible, but provided you give them access to assistive technology. You neither have the research. In fact, we were in a meeting, WHO Regional Technical Group meeting on assistive technology products, and this was in Bali. And there was a person who was presenting a session on research in artificial intelligence and the software development for persons with disabilities. And it was fascinating the way he narrated. I asked him, tell me, how many such centers do you have in Italy? He was from Italy. His answer was, we have 6 such centers. If you look at the population of Italy, if you look at the disabled in Italy, 6 centers for a small country. And in a nation like here, how many dedicated research centers with research budget dedicated for research to look at outcome, to look at quality of care, to look at generating data and, to change outcomes? We will fall really, way behind the high-income countries. Whereas to do a population-based study in India, and I've been part of population-based studies where I went every week to a rural area. Every week for 2 years, I was visiting house to house, and I was all examining them on the floor of the village houses, and I was examining disabled persons. So when I did that, when people heard my presentation in one of the US meeting, they said, amazing, how expensive was it? They thought it would be horrendously expensive to do a population-based studies. Whereas doing population-based studies with population-based, community-based welfare workers, social society workers, it's far easier to do here than in a Western country. Far easier, far cheaper to do. We can do what they can't do. So underserved areas can have community volunteers who can gather data on every spinal cord injury, tetraplegic, paraplegic, on everybody with a bed sore, do a bed sore supervision. So you can look at very simple research, very robust and huge numbers. Possible provided you have the willpower and even a little bit of investment. It is an investment, as I say, healthcare, interventions and research is always an investment. For research in these areas will go a long way in convincing the policymakers and helping with this will be a helping hand to the advocacy people. That look, this is the research done. This is what can make a difference. We must implement it. This is cost effective. Unless we can get that kind of a robust research from even in the underserved areas and show the economic benefits, the social benefits, the family benefit, the individual benefit, we can get the advocacy people to fight for us. All are important.
Thank you, sir. You very rightfully mentioned that whether it's underserved area or appropriately served areas, research is very important. But would you agree that the nature of research may also differ somewhat? And in order to make judicious use of resources, proper research becomes all the more essential in areas which are underserved. Say, for example, in underserved areas, it's not only to come out with innovative techniques of management, but also pioneering research which has brought out use of certain aspects in developed countries, how to make them accessible to the masses, right, through coming out with research such that you can have a lower priced product of the same thing, could be a research which would be useful in the underserved areas.
The catch is, as Komal just wrote in the text, no funding agency. I am part of a research group. I've been going from pillar to post to get funds for my research work. No one is willing to fund for research. They may fund for a patient with bed sore to do a flap procedure for his bed sore, but they won't be willing to do a research proposal which can provide a simple bed care project in a rural area. That doesn't happen. So we need to change our mindset towards research, how it can change outcomes, and we need to look at, even in underserved areas, it need not be. So where you have underserved areas, we can look at basic functional outcome and quality of care by family providers. In fact, the World Bank is looking at the value of contribution of a housewife as a homemaker in a home. Similarly, a caregiver in a spinal cord injured patient's family, who's a family member, there should be a cost ascribed to it, and you can look at cost inputs of this. Put an economist on the job, calculate the cost input for that caregiver, and say that, look, by family-based care, this is the value of money that we are saving, and we need to provide training accessible to these people, whether it is group rehabilitation, whether it is a family mela, whether it is whatever, to change the outcome. We can convince the policymaker it makes a difference. We must go for it. We must go for it. And that's the way. But at the same time, while we do this, we must also have tertiary care and quaternary care facilities where we'll do cutting edge research. Yesterday only I was reading a paper on head injured patients, why there is so much of newborn formation. They found an mRNA vesicle that is released from hippocampus, which improves the osteoprogenitor cells and increase the bone formation. Until now, we did not know why patients with head injury have fracture healing. So these kind of little details, impulse from brain controlling paralyzed muscles. These are cutting edge researches. We can do it at much cheaper cost. Our ISRO cost for Chandrayaan was cheaper than an Innova being hired on the streets of Delhi. 16 rupees per kilometer was the cost of Chandrayaan, and that was cheaper than the cost of an Innova hired in Delhi. So if we can do it that level, we can do cutting edge research. Only we have to have mindset, give that much, that 16 rupees per kilometer has to be invested. Without that, it won't happen.
And to just add to that, most of the people involved with the ISRO research were not top-rung researchers, because most of them get, that was also a report in that even the person who headed the project, right?
Most of the top-rung institutions, they create manpower for export. They go to the US and Europe and Australia and New Zealand. The ones that do not get to go abroad, we have done work in this. Professor Dinesh Mohan in IIT Delhi, we did a work on this, and it was clear that people that stayed back for PhD research work in Delhi and IIT institutions, they were not the ones. They were not the ones who were the grade point average toppers. They were not the ones. These were the average people.
Right.
And they continue to stay back in country and contribute to the country.
Yeah, I would only want to add, because it's an important topic, Dr. Matthew Varghese, that in emerging countries like India, you mentioned about the need to have proper research, but also the focus on transdisciplinary research is also lacking. So like there are so many engineers who are wanting to know about ideas on which they could carry out research, whereas doctors don't have the time or the energy to go into that. But if we get them all to the same platform and brainstorm and have transdisciplinary research, we can have better outcomes in that regard.
Certainly.
So, right. Thank you, sir. Now, moving on, just highlighting some of the it is clearly established that research endeavors can have a major impact on spine care programs. And with cooperation and funding, it is possible to conduct. The catch there is funding. It is possible to conduct the research necessary to provide sustainable spine care programs that have the potential to improve public health and quality of life. And by innovativeness, in India, what we call that as jugaad, right? Like reusable catheters, use of cotton cloth bag for storing catheters. Even the WHO recognized this as a viable option. The floor mobility device, right? Because Indians need to work on the floor very often and can't work from the wheelchairs. Use of honey and vinegar for pressure sore dressing, again, established by research. Then similar techniques for management of pressure ulcers, right? So there are various techniques which, by innovation, we can come out with low-cost measures which have an impact on patients. So, coming to the next question, and here I would want to request Dr. Gaurav Sachdev to address this. How can targeted education, professional retraining, and professional oversight improve access and quality of spine care in underserved areas?
Thank you, sir. Incidentally, there was an article published today in Times of India which talked about treatment of spinal cord injury in rural India, and I believe that must be part of the World Spinal Cord Injury Day commemoration, which we all celebrate tomorrow on 5th of September. And if I can quote that article, it says, an approach that will streamline patient referrals through village health workers after empowering them with red flags, equipping primary health centers, district hospitals, orthopedic units with primary golden hour intervention and escalate, and transfer cases to specialized hospitals whenever needed. That has actually worked as one way of managing these patients. And this is one such example of a pathway where we can initiate early specific intervention for patients with spinal cord injury. And even the theme for this year, Spinal Cord Injury Day, itself says it all. It talks about access to spinal cord injury, a life less complicated. So we need to plan things out so that, yes, our patients on wheelchair, they can get access to spinal cord injury services wherever they are. Like Professor Haria also mentioned about that rural area. I mean, we should plan it such way that all such areas should be included. Thank you.
Thank you, Dr. Gaurav. Dr. Sanjay Wadhwa, would you want to add to this?
Not anything new, but I agree with the panelists, what they have said so far.
especially with regard to targeted education or professional retraining and professional oversight? Can it improve access and quality of spine care?
There is no doubt about it. But then problem is that we are trying to teach too many people, and there are not enough number of teachers or trainers. Anybody cannot play the role of a trainer or a mentor or a teacher. And our teacher training programs are very weak. So that also has to be looked into. Anybody who has, for example, in the medical profession, if I may say, anybody who has done post-graduation, then becomes a senior resident, does not have all the essential attributes to be called a teacher or a faculty member. So that is where the problem, and people become professors by way of some 4 years, this slab you clear, then 3 years you clear this slab. There was a time when professors used to be very few. Now in any large medical institution, the pyramid is top heavy. Earlier it was a proper regular shaped pyramid. Base was very broad. Most of the people used to be assistant professors, smaller number associate professors likewise. And now, for example, I know about specifics of the AIMS. Now there are more professors than assistant professors in AIMS. And the more senior you become, the more far away from the patient you move. Most of the patients are handled by the junior staff and the trainees. That is a sad reality. There are exceptions, of course, everywhere, but I am talking of the general experience. So the curriculum development is generally left to the people who are not much interested. Busy clinicians are not interested in curriculum development. They are not interested in teaching and training.
Thank you.
I think Dr. Wadhwa raised a very, very valid point. Where are the teachers? You're creating so many aims, but where are the teachers? You go to any of the All India Institute of Medical Sciences, how many of the posts are lying vacant? How many of the PMR departments are manned by competent people? You may have a person with a limited experience being there as a filler of a post, but that doesn't make him a good teacher. That doesn't make him a good clinician. That doesn't make him a person who can guide policy or help advocacy people to advocate for the right policy or the right guideline.
I agree. And there was a trend also, and it is still continuing, opening up of so many colleges of physiotherapy and increasing the capacity of the batch every 3 years or 4 years. But again, many of the people are not being trained properly even in the physiotherapy. The skill.
Unfortunately, most of the physiotherapists who trained and who have a little land and a little money, they open up gyms all over the urban area.
Yes.
So most of them are manned by PTs who have not found a job, who found some land where they can create a space for gyms.
Yes. They are becoming fitness trainers.
Yes.
Air-conditioned gyms.
Yeah. But I think that is more relevant for the occupational therapists who also open, other than opening gyms, work like physiotherapists and do not work in the specialty they have been trained for. Well, the need for having teachers only, as you had rightly mentioned, it only focuses on the fact that no one strategy can resolve everything. You have to have multitude of strategies. Unless there is good policy making, then targeted education will not be effective because proper trainers have not been created. So you need to have a proper overall strategy in this regard. I think you would all agree on this. Now, just coming back on this, transforming and scaling up health professionals' education and training, right? WHO says that in assessing whether a health workforce that fulfills its social accountability mandate to the population it serves, the education regulation system of health professionals should be assessed in terms of its impact on quantity, quality, and relevance on the basis of appropriate indicators. That is, how should the effectiveness of regulation be measured? It's in these terms. And by combining local input and evidence-based sources, models of training can be devised to improve pre-hospital trauma care, or in fact, any care rendered in low-income countries. This was the conclusion of another study which was there. I would just request all panelists, we are coming towards the end of this session.
Incidentally, Dr. Chavda.
Yeah, sure, sir.
The paper that was presented from Africa,
Right, sir.
they used a first aid book that I had created.
Oh, wow. Wow, thanks, sir. So we right. कहते हैं हिंदी में चिराग तले अंधेरा. So we.
I recognize the names in the paper. Charlie Mock. It was led by Charlie Mock, WHO.
Right, sir. Right, sir. So I will request all our panelists in bullet points to mention what they feel about 4 bullet points on appropriate strategies to overcome the challenge in management of spinal cord injuries. I would start with Shivjit ji.
See, one, I would say now education of the family of the and the individuals about spinal cord injury who have these injuries, as a person with spinal cord injury and their family. That is one. Second is that we have to have coordination among the professionals and the end users for advocacy with the government and policy makers. Because alone, they each may not be heard, rather, but together we can really make a difference, rather. Third is that the reach, we have to start outreach towards the rural and far off places where enough care and management facilities are not there for spinal cord injuries. And fourth, definitely we have to work more on prevention rather than creating centers. That should be the 4 points from my side.
Thank you, Shivjit ji. Vishakha ji.
Yes, sir. So, like sir has mentioned, we need to have more of ground workers, as in the, I'm sorry, okay, like the ASHA workers. We need to train more of the people in the rural areas about the prevention as well as the initial management, so that they reach proper tertiary rehab center, proper care centers. And yes, public support and policymakers have to work together, like to get better of the policies for the strategies to overcome. And I believe, like, basically major of the education and good research work. That's all I can say.
Thank you. I think Nikram ji wanted to make a statement. Before that, Dr. Sanjay Wadhwa, you wanted to comment on what has been mentioned.
A small point of disagreement when Vishakha ma'am mentioned about the ASHA workers. See, I am aware of the ground realities. Whenever a new idea is introduced or any program is to be launched, there is always a talk, then let us train the ASHA workers. And if you prepare a list of the healthcare programs at the national level, which the ASHA worker has to carry on in the peripheral areas, it is mind-boggling. And how lowly are they paid? The support and resource available to them are very meager and limited. So I am not at all in favor of burdening ASHA workers more. Rather, WHO many years ago had come out with a strategy training the mid-level workers. That concept has to be revived. Burdening ASHA workers will burden them more, they will collapse. And no new cadre will be joining the ASHA workforce. That has been the experience in the ground. Thank you.
Yeah, thank you. Since you were talking, Dr. Sanjay Wadhwa, would you want to give your 4 bullet points, and then we will come to Nikram. He wanted to make a comment, and I think we can't know his name because he's joined from the iPhone. He wanted to also add something to the discussion. So we'll come to that before we go to the other panelists. But before that, Dr. Sanjay Wadhwa, your
No,
4
actually,
bullet points.
I will just use an example from a very common or very famous interview of a celebrity. And the question asked was, how does success of a film is ensured? फिल्म कैसे चलती है? उसका जवाब था, फिल्म 3 चीजों से चलती है. पहला पॉइंट एंटरटेनमेंट, दूसरा पॉइंट एंटरटेनमेंट, तीसरा पॉइंट एंटरटेनमेंट. सो अगर फिल्म एंटरटेनिंग नहीं है तो वो नहीं चलेगी, चाहे स्टार कास्ट कुछ भी हो. बेसिकली जो आप 4 पॉइंट पूछ रहे हैं, मैं 4 पॉइंट के बारे में सिर्फ 3 पॉइंट्स कहूंगा. एक्चुअली फोकस हैज टू बी ऑन education, and education has 3 main components: the knowledge, the skill, and we neglect very often the third important component, that is the attitude. What kind of attitude we are going to impart to the trainees? And attitude is not something which can be imparted through the textbook. It has to be through the role play. Our mentors have to demonstrate in their day-to-day practice the key assets of the attitude. What kind of attitude we want of the healthcare manpower towards persons with spinal cord injuries specifically, or towards any person with disability in general. So we are focusing too much on the knowledge, a little less on the skill development, and the least on the attitude. So this kind of distortion has to be corrected. That is my last point. Thank you.
Thank you, Dr. Sanjay Wadhwa. There is a comment by Dr. Komal Kamra. Why talk of rural areas when class 1 hospitals in A-class cities still send back spinal cord injury persons home without any rehabilitation? So that is lack of awareness, Komalji, and that's what we are trying to do or address when we commemorate Spinal Cord Injury Day. We still have a long way to go, but we have to make a beginning and we have to move on with that. Nekramji, you were wanting to make a statement about the differences between gyms, right? There are various kinds of gyms which are available, right?
Sir, I just wanted, because since the other audience is also, I think that the physiotherapy fraternity and other people, since you're pointing out that these people find some land and open up a gym, so it would be good if we can briefly talk about what are the difference between the physiotherapy gym and the physiotherapy clinic that we're supposed to have. So it would be beneficial, and then I think it would be very informative for those fraternity also. Thank you.
So what is your idea on that? Do you think... right.
I think I'm not from that area though, but I'm kind of, from point of view of physiotherapists, because I'm just asking this question because they might be little feel demotivated, what I feel, because if you call them a gym.
No. Please, I think you should, I was very clear on this. It was not meant as a demotivating thing. It was basically spent only because when you create a manpower without planning, then you create an overburden of people out there who do not get jobs. It is a comment on our policy planning that we did not plan for them. They are forced to do these kind of things. Whereas they are trained to be good physiotherapists, they can do a huge service and these people can make a huge difference. But out of sheer compulsion that no jobs are available, they may not have the resources to do other, travel abroad or whatever. So therefore they end up doing this, which is out of compulsion, not by choice. And not all of them. Many of them are just they're not even physiotherapists. They're just people who, own a land, that's all. They're not physiotherapists at all. So I didn't mean it in that sense. So please don't even, I apologize if it was conveyed like that.
No, sir. No, sir. I
No.
really admire you. I even commented on you pointed the assistive technology. I really happy that you talked about assistive technology. This is what actually wanted to be added a little bit. So I think you made the point clear. I'm happy. So I think this is all I think to make it a little more clear. Yeah. Thank you.
I think the same would hold true for occupational therapists. They are forced to start a physiotherapy clinic or anything else just because they don't have enough job opportunities in occupational therapy, or just because that.
You look at the corporate sector. If you look at the corporate sector, most of the corporate sector have physiotherapy services as outsourced to a group of people, not as mainstream employees of those major hospitals. So, which is unfortunate. Why can't they be mainstream? They should be mainstream. They are competent professionals. They spend 4 years in training as much as the doctor does. Why not?
Yeah,
Dr. Chabra, may I
Sanjay
pitch in?
Wadhwa.
Can
Yeah,
I?
Professor. Yeah, sure.
Yeah, I was listening to the conversation deeply. I am from physiotherapy background. Just to throw more light into it, physiotherapy has come a long way in these years as they enter into all the 4 tenets of medical practice that may be health promotion, prevention, or a curative part of medicine, or rehabilitative. So many people nowadays, by choice, they enter into running a professional gym because there is a lot of calculated dosimetry which has come for normal individuals or abnormal people with some diseases. So it is by choice also many people because they find it to be more lucrative. Like as I said, the 4th part of medical practice is rehabilitation, where this SCA type of injuries or traumatic and brain injuries or anything. So it is by choice a person comes into either getting into working with the normal people by promoting fitness and promotion, or by choice they wanted to be with rehabilitation as their core area of work. So in these years, it has come up so well that so many techniques, hands-on, plus gadgets. Now artificial intelligence is there inside. So many things are there. It is by mere choice and willingness they get into this sort of gym, having the chain of gym data.
We respect the choice. There is no problem in that.
Yeah, that's how they. But there are a good number of people who work into SIRC, like this sort of rehab comprehensive programs and cardiac rehab programs. There are so many such things.
My comment was on the policy without planning.
That's absolutely all right, sir. I agree to that. It is without planning, nothing works. Yeah. This is just regard to Nikram's question also. So it is, gym is absolutely different and clinic is absolutely different, where clinic we get into people with some diseases or some problems. And this is more towards fitness and promotion, where they run chain of gyms. Yeah.
Dr. Sanjay Wadhwa and then Dr. Sanjay Pandey.
Dr. Chabra, I just have a small comment to make. I know we are running behind schedule and there is a meeting at 9 o'clock also that both of us have to attend. So I will just make a quick comment. This confusion regarding the overlapping areas or difference between a physiotherapy clinic and the fitness center or a gym. See, first of all, let me clarify. I have great regard and respect for all allied health professionals because healthcare delivery system is a teamwork. So many of my good friends are therapists. So I value their contribution and role and the change they bring about in the life of the patient. There is a Clinical Establishment Act which defines what is a physiotherapy clinic, what kind of space, infrastructure, other requirements should be there to be called a physiotherapy clinic. So I think we need to refer to those kinds of government approved documents and definitions. And there is similarly a definition for the fitness center or a gym also, like because a large country like India cannot function without clear demarcation and specific definitions and all. And my last point is that many times when I sit in the selection committee meetings, there are many colleges in India which are providing postgraduate level training in physiotherapy. There is a need for that. But then, as Dr. Matthews said a short while ago, there are not enough jobs in the government sector. So what I see is that there are many applicants in the interview who appear after doing bachelor course in physiotherapy, then masters in physiotherapy. They are coming to us with some diploma level qualification from IGNOU and similar institutions. diploma in hospital administration, diploma in healthcare administration, like kinds of, there are so many diplomas offered. So basically, I don't know whether this is the right approach or this is just a stopgap arrangement because they are not getting the job. वो सोचते हैं चलो एक और certificate या एक और qualification ही add कर लें. So government needs to work out a policy. What is the manpower need and requirement and how to train them and how to retain them. That is important. Thank you.
Yeah, I think it is sad that in a country where still the professional is to patient ratio or the population ratio is far below the average.
Yeah, just a last
And-
half sentence, if you allow. It is not
yes,
so
sir.
much of deficiency of trained manpower. It is an absolute maldistribution. People, after receiving training from the best of institutions, do not want to move to the periphery. And that is where we need much more and many. It is a maldistribution. Everybody wants to concentrate in the capital of a state or a large city. That distortion has to be corrected.
Dr. Sanjay Pandey wanted to make a comment and then we'll move on quickly.
Yes, sir. Good evening, sir.
Good evening. Good evening.
Sir, I agree with the panelists. Actually, I joined late a bit. But sir, obviously, I agree with that. The policy, the planning, the execution, the implementation, and especially Dr. Matthew's sentence, the robust research is very much needed. Because I belong from Patna and I don't know, actually we have the data regarding exactly how many beds of or how many IPD beds are available in entire country for SCI. Apart from that, suppose SCI patient managed with conservative management or operative management. Ultimately, we all know they need rehabilitation. So coming to that, the research area actually emphasizing here, sir, we have not researched the Indie research or our country research. What is the rate of recurrence, prevalence of recurrence of pressure ulcer? Those pressure ulcer we healed with our effort at our IPD. And the same patient came to us with the same pressure ulcer, in fact, aggravated pressure ulcer. What is the reason? What is the compliance for converting from IC to CIC, again coming back to IC? So these are the very small things that I am talking about. The patient only wants his bowel and bladder control, which we provided to some extent during our IPD care. But actually, how many IPD beds are available in Tier 2 or Tier 3 city? And there is no research. So actually, I am urging our all panelists and also myself, we must, sir, do something regarding this robust research, robust data from our own country to realize the gravity of the problem itself. Then we come to the planning or robust planning also. Then come the implementation and execution, sir. Thank you, sir.
Point well taken, Dr. Sanjay Pandey. As you last in the end mentioned, the gravity of the problem, right? We still don't know how many spinal cord injured would be there in the country, right? What is the common cause? Because we don't have a proper database, leave aside a registry. So we still have a long way to go in this regard. We will come to Dr. Balamurli, your 4 bullet points, quick bullet points. We are running out of time. So apologies. Quick. Yeah.
Yes, sir. I think we've discussed a lot. There are lots of stakeholders in this. So the 4 points I'll make is, see, one is healthcare. So the healthcare systems and the healthcare in public-private or public-private partnerships should really be alerted and should work towards rehabilitation in general. Second is medical professionals. So medical professionals, we've all discussed that we have to increase awareness from medical student, post-graduation, have more rehab courses and post-graduation, and this lack of availability. Then comes to the community. In the community level, there's a lot of work to be done and awareness to be created among the public, both in prevention as well as how they deal with people with spinal cord injury. And finally, I think the last point which was taken about database and a multi-centric association of research workers, the end care users, professionals, therapists. So we all need to get together and discuss more about these issues and come up with policies. So because there are so many stakeholders in this, I think these are some of my important points.
Gaurav? Dr. Gaurav Sadhya?
Sir, I think everybody has talked about a lot of points, but one point which I thought was missing was awareness about PMR or rehabilitation amongst medical professionals itself. I think we are even lacking that to an extent. Forget about awareness among SCI population or amongst common man. Even medical professionals, they do lack awareness about what all a PM or rehabilitation can do to a person with SCI. Thank you.
Thanks, Gaurav. I think even among the medical professionals, when you talk about, they may not know the difference between an occupational therapist and a vocational therapist. They think of that as synonymous, right? So we have a long way to go, and that's how we need to create awareness. Nishad Qasim ji?
Yes, sir. So my 4 bullet points would be: one is like creating a comprehensive policy with prevention, promotion, and management. So that is one. The second one probably is putting forward a guideline, and this guideline has to be educated well to all levels with appropriate roles and responsibilities. The third one, basically an affordable transdisciplinary model which reaches the last mile. And the last is reporting whatever works that we are doing. I'm unsure whether a research at this point of time is an initial step that we can do, but reporting what all that we do in the communities or at multiple sectors to a common platform really help us to design something in future. So that these are the 4 point highlighters that I would put forward. Thank you, sir.
Yeah, but there's a comment in the chat box from Anu Manocha. She totally agrees with the panel. Physios are not trained properly. Again, a lot depends upon the attitude of the trainers and the trainees. Many physios just want to get a degree. Most of the good physios leave country as there is not much of a scope in terms of jobs or money for them. And the ones left get into getting other certifications to amp up their income. So thanks, Anuji, for pointing this out. Professor Harya, have we asked you about your 4 bullet points? Not as yet.
No, not yet, sir. Should I?
Yeah, please.
Should I?
Yeah, sure.
Yeah, the most important, I would like to reiterate the same thing, the acronym GRIP. There are so many research which has been done. Getting research into practice, I feel, is the most important thing. Already existing data, whichever is there in the research bank, needs to be disseminated to all the professional across, including the patient community, where those things are put into practice. That is the first thing which I feel. Second most important is, again, Dr. Bala said, multi-centric research work where we have a nationwide data, and from there we can take off to give what next is needed, having patient-centric approach and including patient as part of a rehabilitation program, keeping them in the center and all the professionals work for them. That is the second thing which I feel. And third most important is this IPE and IPP component, interprofessional education, interprofessional practice. Interprofessional education is nothing but learning from, about, with each other, learning from each other, learning about each other, learning with each other. The multiple professionals come together to learn from each other about their roles and domains. That is the third important. And the last most important, again, going into the community to see, the most important is again, I'd like to recall the saying, prevention is better than cure. So the Spinal Cord Society needs to work more on prevention and prevention strategies. Of course, we could able to reduce the the burden that economy faces by putting more efforts on prevention. These are my 4 important bullet points, as you asked.
Yeah, Dr. Harya, we will be brainstorming over the coming weeks also on a national spine care program, because we need to present that to the ministry. And I think there are more of such issues, discussions which will take place. I think other than Dr. Matthew Burgess, we have asked everyone from the bullet points. Have we left out anybody else? If not, then I will request Dr. Matthew Burgess to give his viewpoint on what are the most effective strategies which are likely to impact.
I think that is across very clearly that the top priority is prevention, because the rest of the things, are required only if we have failed in our prevention effort. So the top priority remains prevention, and we must go all out, advocacy and whatever, to do a preventive policy making for that. I would like to segregate my 4 bullet points into 4 sections. One is the emergency care. My top priority would be protection of bladder in the acute phase. I have seen many a patient who have had treatment in medical colleges, but the catheterization, when I asked them, happened after 24 hours. by then the bladder is grossly over-distended damage. So protection of bladder as top priority in emergency care in every medical facility, in the emergency room. So herein you need to look at training, that's another component. Promotion of long-term care, whether it is bedside, bladder, bowel management, at the community-based approach. That is the second approach that I would say, because these are the things that reduce their life expectancy. Then the third point is create and plan for policy and invest in them, and particularly at different levels. At the primary care, where the patient from the rural area is going, red flag should be there. Red flag for a spinal cord injury patient presenting with Thrive should be there in the emergency room. Red flag for a patient presenting with spinal cord injury in a circular district hospital. The same thing in a medical college hospital. The same thing in wherever emergency room should have a red flag recommended by the spinal cord injury group that we have in India. Promote that and publicize it in every emergency room. Then training of trainers becomes an important part, but training, one has to remember, spinal cord management is a team approach. So we have to have a good way of assessing how many places in the country can create a team where an occupational therapist, a physiotherapist, a urologist, a neurologist, a orthopedic surgeon, and a neurosurgeon can sit together and take care of the patient as a team. We need to have a clear bullet across the country in every state. How many centers are there with these kind of expertise available? The health ministry, the Ministry of Social Justice should have immediate on their fingertips. The secretary should know how many centers are there where a person can get comprehensive care. Create, designate comprehensive health care with trained people. Training of trainers also have to be planned. Look at your statistics, look at your database, identify what numbers are required, plan for number of trainers, plan for number of training of trainers. Plan and create them intelligently. Invest in research. That's the fourth point and the most important point. Invest in research from the most basic, simple data gathering to cutting edge research in tertiary care facilities, including like what was happening. Look at spinal cord regeneration of cells. What are the cells? What are the stem cells? There is a research committee formed in ICMR. I'm a part of that, where we are looking at stem cells research, which are being done across the country. We're looking at guidelines, how it can be done. So those are important points. But again, remember, the future of science, Anthony Giddens, one of the most prolific scientific writers, has written this. The future of science, cutting edge science, will be based on intersectoral research. So intersectoral department of neurology, neurosurgery, basic sciences, stem cell research, physiotherapy, occupational therapy, urologists all team together and create an intersectoral team in centers of excellence where you can make a difference to these people, not only today, but for the future. Thank you.
Thank you, sir. We have had very important points, but I think we need to have judicious use of resources and we need to prioritize. So one area which probably didn't come out was pre-hospital care, something which is grossly lacking in our country. And I'll just give an example which I always give. In the US, when they initiated pre-hospital care on a war footing in the 1970s, we are still in that era, to 1986, there are statistics that they were able to reduce the mortality from 33% to 4.2%. And they were able to reduce the percentage of complete injuries from 62% to 21%. Imagine. And this convinces me that one of the most important components of spinal cord injury care, if not the most important, is pre-hospital care. And this is something which is sadly missing in our country. So we need to prioritize, make judicious use of resources, and we need to move forward accordingly. Friends, we have run out of time. You just want to conclude, listening to an underserved population is how you begin to understand them and serve them better. The personal satisfaction of doing good in the community and increasing value and holding true to the Hippocratic oath and being able to provide services to those that are in need is very strong moral reason to provide services for the underserved. And friends, we know that in underserved areas, persons with spinal cord injury are the most underserved. We have had various comments from Dr. Komal Kamra in the chat box, which also point out to that. Friends, it is in our hands to create a better world for all who live in it. Let's join hands to improve spine care in underserved areas and to alleviate the burden of spine disease. We will be in touch with you as we try to work on a national spine care program and try to lobby for its implementation with the government. And we are very hopeful. We think the Director General of Health Services was there in our event yesterday, and he is again quite motivated. But it's still a long way to go, but we are sure we will reach there. Together, joining hands, we should be able to make an impact where it matters the most. Thank you, everyone, for joining the session today. We would want to invite all of you again day after for another panel discussion on injury prevention. And just a comment from Anu Manocha again. Would like to say we need quality of dedicated people than just quantity of people, be it the education sector, research, or primary healthcare. Totally agree with you. And we look forward to having you again in our subsequent events. Thank you. Thank you very much for joining today.
Thank you for your incredible energy in conducting this. You seem to have indefatigable energy to go on and on.
No, sir. Thanks. When there are very eminent figures like all of you there, the energy, I think, pilfers by itself. Thank you.
Thank you.
Thank you so much, sir.
Thank you.
Thank you.